I want you to picture two headlines from the same era. One says hormone therapy doubles a woman's risk of dementia. The other says hormone therapy protects the brain, especially for women with the strongest Alzheimer's gene, APOE4. Both headlines discuss the same treatment, but they reach opposite conclusions, and both are based on real data. It's understandable if you feel confused. The information available almost makes it certain. If you've ever asked your doctor or searched online late at night wondering if hormones will help or hurt your brain, this episode is for you. Today, we'll take a look at three main studies behind most of the headlines and compare them. We'll see why they seem to disagree and why, once you know who was studied and when, they mostly don't. Welcome back to the Healthy Life Approach podcast. I'm Kristen Beasley, a certified functional medicine, nutrition, and brain health coach. I focus on the point where midlife hormonal changes intersect with women's first questions about their brain health. This topic is personal for me. My father, Gene Austin, lived with Lewy body dementia. He was an engineer who could solve problems that few others could solve, and I watched that disease take away what made him special. So when a woman shares her fear that her forgetfulness is the start of something bigger, I take that seriously. That's why I do this work. Before we go on, I want to be clear. I'm an educator, not a doctor. Nothing in this episode is medical advice or a recommendation to start, stop, or change any medication. Those decisions are between you and your clinician. My job is to explain the research in plain language so that you can have informed conversations with your doctor. That's what this show is all about, building your base, knowing your numbers, and owning your outcomes. So let's begin by building that base. Here's a fact that should be front page news, but often isn't. Women make up almost 2/3 of all Alzheimer's cases. For years, people said it was just because women live longer and have more time to develop the disease. While living longer does play a role, it's not the whole story. Researchers like Dr. Lisa Mosconi and Roberta Britton see things differently. They say menopause isn't just about reproduction, it's also a neurological event. Estrogen doesn't just pass through the female brain, it helps the brain use glucose for energy, supports connections between neurons, and helps clear out the waste. When estrogen levels drop during perimenopause and menopause, the brain must quickly adjust to its energy supply. This adjustment is why so many women in their 40s and 50s experience brain fog, trouble finding words, and feel less sharp. It's also why the question of hormones matters so much. If estrogen affects the brain, the next question is whether replacing it helps. Three major studies sought to answer this question, but their results initially appear to disagree. Much of the fear comes from a study called WHIMS, the Women's Health Initiative Memory Study, published in the Journal of the American Medical Association in 2003. WHIMS is an important study. It was a randomized controlled trial considered the gold standard because women were randomly assigned to receive treatment or a placebo. This design helps remove bias that can affect other types of research. So when WHIMS reported harm, the medical community paid attention, as it should have. Here's what WHIMS found. Women who took a combination of oral estrogen and synthetic progestin had about twice the risk of developing dementia compared to those on a placebo. That's about 45 cases per 10,000 women per year on treatment versus 22 per 10,000 women per year on placebo. The group that took estrogen alone had a smaller increase that was not statistically significant. Overall, the combined risk increase was about 76%. Those numbers shape the story about hormones in the brain for the next 20 years. Doctors stopped prescribing them, women stopped asking about them, and a whole generation learned one message: hormones cause dementia. In fact, it was on the black box warning for estrogen products until the FDA removed it in November 2025. But let's look more closely at that message. Every woman in WHIMS was at least 65 years old, and most started hormone therapy more than 10 years after menopause. The treatment was a specific oral combination of conjugated estrogen and synthetic progestin. WHIMS didn't test whether hormones help a 50-year-old woman going through menopause. It only looked at what happens when this specific treatment is started in women already in their 70s. So the real headline should have been, this formulation started this late and women this age increased risk. The world held on to that scary headline even as science moved forward. 20 years later, a new picture started to emerge. So I want to walk you through two studies that help reframe the question. The first study is the EPAD cohort, so EPAD. the European Prevention of Alzheimer Dementia Initiative, which was published in 2023. EPAD studied nearly 1,200 women and asked a more focused question than WHIMS. Do your genes affect how your brain responds to hormone? They looked specifically at APOE4, the most common genetic risk factor for Alzheimer's. The results were striking. Among women with APOE4, those who used hormone therapy had the best delayed memory scores, even better than the APOE4 carriers who didn't use hormones, and better than women without the gene. Brain scans showed these women had 6 to 10% larger interhinal, which is located in the medial temporal lobe, and amygdala regions, which are some of the first areas affected by Alzheimer's. The benefit was strongest when hormone therapy started early during menopause. Think about the irony for a moment. The women at the highest genetic risk seem to benefit the most. That's the opposite of what the WHIMS error fears would suggest. Of course, EPAD was an observational study, meaning it was a snapshot of women at one point in time, not a prospective study, so it cannot prove causation. The next question is whether a larger forward-looking study would see the same thing. That brings us to the second study, which is much larger. In 2025, researchers released a UK Biobank analysis, which is currently a preprint, that followed over 183,000 postmenopausal women for an average of 13 years. This study isn't just a snapshot, it's more like a long movie. The main finding was this: women who used hormone therapy for at least a year had a lower risk of dementia. That drop was about 10%. That is a small effect on its own. But when researchers looked at smaller groups of women, the picture got more interesting. The benefit was bigger in the groups you would expect. Some women go through menopause early because of surgery, such as having their ovaries removed. In that group, the risk dropped by about 24%. Another group carries a gene called APOE4, which raises the risk of Alzheimer's. In that group, the risk dropped by about 13%. And women whose bodies made less of their own estrogen over a lifetime saw a drop of about 22%. That APOE4 result matched a smaller study we just talked about, only now it showed up in a far larger group of women. Timing mattered too. Women who started hormone therapy between the ages of 46 and 56 had a lower risk. So put it together. One study was small and focused on genes. The other one was huge and followed women for years. Both pointed the same way. And that way is the opposite of what the scary 3 headline led everyone to believe. Here's what I want you to remember. These 3 confusing studies actually tell one clear story. These studies aren't really in conflict. They answer different questions about different women at different times. WHIMS tested a specific oral hormone in women more than 10 years past menopause and found harm. EPAD and the UK Biobank looked at women who started hormones around menopause and found benefits, especially in those at a higher risk. Researchers call this idea the critical window or the timing hypothesis. It suggests that the same treatment can have different effects depending on the brain's condition. A brain in its early 50s still adjusting to lower estrogen might benefit from hormones. A brain in its 70s after years of changes might react differently. This is a real hypothesis with growing support, but it hasn't been proven by a large randomized trial yet. This difference matters. WHIMS, the study that first caused concern, was a randomized controlled trial and offers the highest level of evidence. In contrast, EPAD and the UK Biobank are observational studies. These can be influenced by a phenomenon known as healthy user bias. Women who choose and stick with hormone therapy often have more resources, better health care, and regular follow-ups. Some of the positive results in these studies may reflect those advantages rather than the effects of the hormones alone, which even the researchers note. The real takeaway isn't simply that hormones prevent dementia or that hormones cause dementia. The truth is more nuanced. The age at which therapy starts, who is being treated, and which type of hormone is used all play a role. Unfortunately, most of headlines turn these 3 factors into a single shareable statement. There's one more factor I think is especially important, and most large studies can't separate it. That factor is the route of administration, or how the hormone gets into the body. WHIMS tested oral hormones taken as a pill and processed first by the liver. Despite its size, the UK Biobank study couldn't separate oral, transdermal, and vaginal delivery in its data. So when the study talks about hormone therapy, it often mixes delivery methods that work differently in the body. This isn't a minor detail. A 2025 study in the journal Menopause by Glenn and colleagues showed that absorption can vary a lot between women using transdermal estrogen. two women use the same patch or gel and end up with very different blood levels. If absorption varies this much, then studies that can't track the delivery method are measuring something less clear than it seems. So let me share a quick personal example, not as advice, but just to make this point clear. I work with my doctor on my hormone care, and I switched from a transdermal approach after we found I wasn't absorbing it well. The takeaway isn't that one method is always better. It's that the dose on your prescription isn't always what your body actually gets. And the only way to know that is to measure, track it, measure it. This isn't just a podcast slogan. It's the real gap between what studies can measure and what happens in your body. You listen to this show because I don't just push one viewpoint. So let me lay out three main perspectives honestly. The functional and integrative perspective, which is my background, tends to see these newer studies with hope. It views estrogen as important for brain health and sees the critical window as a real opportunity. This optimism makes sense, but it can get ahead of the evidence if it treats observational findings as settled facts. The mechanistic research perspective, led by scientists like Mosconi and Britton, focuses on why estrogen matters for the brain and is building the biological case step by step. This group is hopeful but careful and reminds us that understanding the mechanism isn't the same as proving a clinical benefit. The conventional perspective, represented by major medical societies, is more cautious. They point out that we still don't have a large randomized trial to prove that starting hormones early protects the brain. Until that study is done, which is expensive and can take years, most professional guidelines don't recommend hormone therapy to prevent dementia. An honest person can hold all three of these views at once. The evidence really is incomplete. If someone tells you the answer is simple, they're offering a certainty that science hasn't earned. I want to be open with you because this show is about sharing my process. I made my decision about hormones with my doctor based on three things: what I saw happen to my father, a mechanism that made sense to me, and a common idea in my field that the big randomized trial might not come soon enough for women who are in the critical window right now. That last point deserves honesty in both directions. The argument is real. A trial large enough and long enough to settle this could take many years, and a woman who is 51 today cannot pause her own biology to wait for it. She has to decide in the face of uncertainty, just as I did. But the urgency is persuasive, and persuasion is not proof. The sentence, "you will miss the window," is exactly the kind of statement that can move someone before she has weighed her own situation. So it is a serious point, not a final argument. So here's the part that matters most for you. Risk tolerance is personal. Mine was shaped by a family history and a diagnosis I will never forget. Yours may be determined by something entirely different, and a different tolerance can lead to a different and equally valid decision. My job is not to hand you my risk tolerance. My job is to make sure you understand the evidence well enough to apply your own. So what do you do with all of this? Not what do you take, but what do you do? There is a difference, and it's the difference between being told to wait and walking in prepared. First, know your numbers. You can learn your APOE status through genetic testing by places like Function Health or 3x4 Genetics, which usually involves a simple saliva or blood sample analyzed for specific gene variants. You can get APOE testing through your doctor, a specialized genetics provider like 3x4 Genetics, or even some direct-to-consumer companies like Function Health. Knowing whether you carry APOE4 doesn't decide for you, but it changes the conversation you have with your clinician because the gene appears to interact with much of the research. Second, know where you are in time. The timing hypothesis is built around the years near your final period. So a simple, powerful thing to know is when your transition began and where you are in it. That is information you own. Third, bring questions, not just symptoms. A symptom can be waved away, but a specific question is harder to dismiss. You might ask your clinician how they weigh the timing window for someone your age. You might ask how the route of administration would factor into their thinking. You might ask what they would want to measure to know whether a given approach was reaching your tissue. You could also ask if your personal or family history of dementia affects the risk or benefits in your case, or what signs and symptoms you should watch for as you start or continue hormone therapy. Another helpful question is, what options exist if the first approach isn't effective, or if there are other ways such as nutrition, exercise, or sleep to support brain health in combination with or instead of hormones? These questions show you've done your reading and they change the atmosphere of the room. 4, track. Whether you and your clinician decide the only way to know what is true for your body is to measure it over time instead of guessing. That is the spirit of the show. Here are a few practical ideas for what you might track. Notice and note any changes in your memory, focus, word finding, or daily cognitive tasks. Keep a list of symptoms such as brain fog, sleep quality, mood shifts, or hot flashes and how they change over time. Record relevant lab results like hormone levels, estradiol, progesterone, testosterone, lipid panels, blood sugar, and other markers your clinician follows. You might even use simple cognitive tests or brain health apps at home, repeating them monthly for a few minutes each time. The more you observe and track, the better equipped you and your clinician will be to notice meaningful patterns and adjust your approach as needed. You are not asking permission to care about your brain. You are gathering information that will help you advocate for it. I think about my father often when I make these episodes. I cannot change what happened to my dad. What I can do is make sure that the women listening do not walk into the most important conversations of their midlife years holding a headline from 2003 as if it were the final word. It was not the final word. It was one study on one group of women using one formulation started at one stage of life. The science has kept moving. You deserve to move with it. So here is your invitation for this week. Find out one number you do not currently know. Maybe it is your APOE status. It may be the date your perimenopause or menopausal transition began. Write down one question to bring to your next appointment. That is building your base. That is knowing your numbers. That is how you own your own outcomes. I'm Kristen Beasley, and this has been the Healthy Life Approach podcast. Take care of your beautiful brain, and I'll see you next week. Disclaimer, this podcast is for educational and informational purposes only. It is not intended to diagnose, treat, cure, or prevent any disease. I'm a certified functional medicine, nutrition, and brain health coach. I am not a licensed medical provider. The information shared here is not a substitute for medical advice from a qualified healthcare professional. Always consult your physician or other qualified provider before starting any new supplement, changing your diet, or beginning a health program. Individual results may vary. Listening to this podcast does not create a coach-client or provider-patient relationship. From time to time, episodes and materials may include affiliate links that may provide a small commission at no extra cost to you. Thank you for being here.